I'm Renu Virmani. I'm going to talk on pathology of COVID-19 induced cardiac injury. These are my disclosures. I'm going to divide my talk into 4 portions. First, I'll talk on the prevalence and impact of myocardial injury in patients hospitalized with COVID-19. Then I'll talk on the prevalence of persistent myocardial injury in patients recently recovered from COVID-19. Then I'll give you an idea of what ischemic injury, that it is common in COVID-19 patients from our autopsy cases, and myocarditis is infrequent in COVID-19 patients. The prevalence and impact of myocardial injury in patients that were recently hospitalized with COVID-19 at New York Mount Sinai Hospital. They admitted 2,736 patients and measured troponin I within the 24 hours after admission. The mean age of these patients was 66 years and 59% were men. 985 patients had elevated troponin I concentrations beyond more than 0.005. And of these, 506 patients had died during hospitalization. They divided the patients of troponin I into 3 groups: 0 to 0.003 nanograms per milliliter, which is the normal range, then those between 0.03 to 0.09, and those greater than 9. They looked at the outcomes of hospitalized, discharged patients and those with mortality shown in orange. And you can see the probability of mortality is extremely low if your troponin is normal range. However, when troponin levels even moderately elevated from 0.03 to 0.09, mortality increases. The mortality is highest in those with greater than 0.09 nanograms per deciliter. So looking at the outcome of cardiovascular magnetic resonance imaging in patients recently recovered from COVID-19, of a total of 78 patients who had recently recovered from COVID-19, 78% had abnormal CMR. Now, I'm going to now address mostly our own work, which is based on autopsy evidence of myocardial necrosis and the type of thrombosis on autopsies that were performed at Papa Giovanni Bergamo Hospital in Italy under the supervision of Dr. Guayumi, who spoke just before me. Now, of the 40 autopsy cases that we've looked at of COVID-19, 32.5% were positive for myocardial necrosis. What were these myocardial necrosis from? 3 had myocardial infarction. Myocardial necrosis occurred in 10, 3 had coronary thrombosis, and 4 of the 13 cases had severe epicardial coronary disease. Intramyocardial microthrombi were seen in 7, and in 2 of the 13 cases, there were LV thrombi, and in 5 of the 13 cases, there were also evidence of lung thrombosis, as shown here. Now, I'm showing you photographs and photomicrographs and some drawings showing dividing our cases into 2 types. Those that had thrombus in the epicardial coronary artery and those that had microthrombi in capillaries. There were multiple in some and there were focal in others. And shown here is an infarct, you can see, and the aspirate of that infarct that patient underwent after he had acute myocardial infarction. He underwent coronary angiography, the aspirate was removed, and this aspirate was examined. And similarly, we did in multi-regional, you can see multiple microthrombi in this case, but in this particular case, it started with microthrombi, which were an ST elevation MI that had occurred in the septal and inferior wall, but also involved the right ventricle. Eventually, at the time of death, it was circumferential microthrombi. This patient had very few microthrombi, mostly epicardial based. Now, as you can see here, what was most dramatic here is the epicardial thrombi are CD61 positive, fibrin positive, von Willebrand positive, D-dimer positive, but C5b9 complement negative. Whereas the microthrombi, on the other hand, are CD61, von Willebrand, fibrin positive, D-dimer positive, but also C5b9 complement positive. Those are the basic differences, and I'll show these differences more dramatically because we assess them quantitatively. We compared the epicardial coronary aspirates obtained from non-COVID to COVID positive patients, N of 5. These are in blank, this is in blue, and the microthrombi are shown in pink. And as you can see, CD61 is not significantly different, but it seems to be increased in those with COVID. Same way, in a way, von Willebrand factor is slightly higher in the microthrombi, but not so in those who have epicardial coronary thrombosis, but this was not significant. Fibrin true was significantly greater in microthrombi, D-dimer was also greater in microthrombi, and C5b9 complement was only present in the case of microthrombi who were COVID positive patients. Now, the findings in the COVID heart suggest an increased incidence of myocardial necrosis. Myocardial necrosis, contraction by necrosis, or focal necrosis, especially endocardial based, is a common finding in elderly patients dying of COVID-19. Similarly, epicardial coronary atherosclerosis severe with thrombosis and ST elevation MI, the thrombi are rich in platelet, fibrin, von Willebrand factor, D-dimer positive, but complement negative. Microthrombi are often observed in the myocardium in patients dying with COVID-19, and the thrombi are rich in fibrin, platelet, von Willebrand positive, D-dimer positive, and complement C5b9 positive. Now, switching to myocarditis. Acute myocarditis is a disease with variable clinical progression and presentation. The pathogenesis of myocarditis consists of 3 distinct pathologic phases. Phase 1, there is direct destruction of the cardiomyocytes through the occurrence of virus-mediated lysis. Second phase is immune response, which is triggered by the myocyte injury and results in infiltration of natural killer cells and macrophages, followed by virus-specific T cells. And the third phase is the phase of dilated cardiomyopathy, which develops as a result of extensive myocardial injury and visible fibrosis. Histologic criteria of myocarditis were first described by the Dallas criteria in 1985, and they defined histologic evidence of intramyocardial infiltrates within the myocardium. These were associated with myocyte degeneration or necrosis or myocytolysis of non-ischemic origin. Then more recently, immunohistochemical criteria have been advanced, and they have overcome the shortcomings of the Dallas criteria. Myocarditis is defined according to the presence of abnormal inflammatory infiltrate defined as greater than 14 leukocytes per millimeter square. These include 4 monocytes per millimeter square with the presence of CD3 positive T lymphocytes greater than 7 cells per millimeter square. And this has been described in 2008 first, and eventually also shown by European Heart Journal as their criteria. I'm going to show you the clinical history and pathologic findings in 16 cases in whom we looked for myocarditis. As you can see, these patients had been ill anywhere from 2 to 29 days, and the heart rate varied according to the underlying cardiovascular disease. Epicardial inflammation was fairly common, as you can see, either mild or moderate, and most of them consisted of lymphocytes. However, when neutrophils were seen, it was usually if there was a myocardial infarction. Now, myocardial inflammation was rare. When it was present, it was mostly consisted of neutrophils, and rarely lymphocytes could also be seen. However, none of these fulfill the criteria of myocarditis. When we look at overall the virus presence, We were only able out of these 16 cases to show the presence of virus in the right atrium or in the left atrium in one case each. And none of these were high enough to be able to say that there was any inflammation seen there. None of them showed us any inflammation. On the other hand, virus was definitely present in most cases tested with for virus in the lung. And if you look at this slide, what we're trying to show is comparison of traumatic death with those of COVID-19 and seeing whether what type of inflammation we see, that is T cell or macrophage. You can see the positive cells, CD3 and CD68, was similar in both, whether they were controlled or COVID positive. However, T lymphocytes were positively seen more frequently in control than in COVID, but monocyte macrophages were more commonly seen in the case of COVID-19 as compared to control, but none of them reached the criteria to call it myocarditis. We also show a case of myocarditis, and you can see very well at low power, you can see inflammatory infiltrate, and you can also see majority are T lymphocytes, very rare CD68 cells. This is a total number of cases that have been published in the literature, 135 cases looking for myocarditis or not. 7 were endomyocardial biopsy, 128 were autopsy cases. And majority are 34 to 94 years in age, majority are males. And if you look at the myocarditis, reported myocarditis was 8.2 according to the authors. But when strict criteria are used, only 3.7 qualify to be called as myocarditis. So in summary, what I have shown you is there is clinical evidence of myocarditis may be considered high, that is 8.2, but using strict criteria, histologic evidence is low, 3.7. Of the 40 cases examined from Italy, we have not seen a single case of myocarditis. Most common cardiac findings in patients dying with COVID-19 is myocyte necrosis from 3 main causes, either epicardial coronary artery disease or microthrombi, and I didn't have time to show you these intramyocardial coronary emboli from PCI or from LV cavity. Thank you.